And I think it makes the transition with the next talk with Professor Palle Osther from Denmark. You know Palle. Palle is one of the top experts regarding intrarenal pressure. And I'm sure that talking about the small size, he will address some point regarding irrigation and intrarenal pressure. Palle, we are listening to you.
Thank you very much, Olivier. I will share my screen here. It's good to see you all your endo friends, although virtually. And thank you, PUSEN, for making this happen. So I will discuss with you whether small size matters in flexible ureteroscopy, and look into the risks of ureteroscopy and the benefits of a small-sized single scope. These are my disclosures. Well, my hospital is located in Palle in Denmark. And Palle is a rather small city in Denmark. And Denmark is a rather small country in Scandinavia. So for us, of course, small is beautiful. So when looking into surgery from the patient's perspective, what is important? Of major importance is the balance of efficacy and safety. And from the perspective of the patient, safety is of paramount importance. So when we are expanding the indications for flexible ureteroscopy, as we have just discussed, it is of major importance to look into safety. And as our old father Hippocrates said, make a habit of two things: to help, or at least not to do harm. So as endourologists, we have to be the gentlest people in the world, because we have to travel through the ureter, and the ureter doesn't easily forgive you. So when you are entering the OR as an endourologist, you better leave your inner gorilla outside, because the ureter is a thin-walled, delicate, dynamic organ with a small lumen in which excessive force may be disastrous for the patient. And we don't want to leave our patients with a ureter, as you see on the left. So taking into consideration the small diameter of the ureter, and especially the narrow sides of the UPJ and the crossing vessels and the uretero-vesical junction, intuitively, a small scope will help you being more gentle in the ureter. And as Albert Einstein said, the only real valuable thing is intuition. And it is like that for us as surgeons. If we don't intuitively feel that the instruments, that the devices that we use, if we don't feel this is safe and it works, we will not use them. So intuition is of importance to us as surgeons, although this is very difficult to embrace scientifically. So let's look at what happens when you are doing a flexible ureteroscopy. When you are placing ureteroscope, the upper urinary tract will change from normal physiology to pathophysiology, because when you're introducing the scope and you're irrigating, the pressure, the intrarenal pressure will rise, and this will give tubular, venous, and lymphatic backflow with potential septic complications, and it may even cause fornicial rupture and peripelvic extravasation and bleeding, as you see on the CT on the right. This is when you exceed certain pressures around 80 to 100 millimeters of mercury, but this very often happens in flexible ureteroscopy. Furthermore, when the pressure increases, strain on the pelvic wall will increase, and this will make pacemaker cells fire, and you will have peristalsis. All who have done a ureteroscopy have seen peristaltic movements when you move up the ureteroscope, and this is due to the increase in intrarenal pressure, and this may cause difficult access. However, and when you are irrigating, the pressure will rise even further. However, as you see on the video on the upper right, irrigation is necessary to have a good vision, and this is also about safety. And irrigation is needed for cooling when we are using these higher power effective lasers. So with regard to safety, there are three aspects in flexible ureteroscopy that's of major importance, and that's the intrarenal pressure, access-related problems, and the temperature when we are using our lasers. And this makes me look into the pathophysiological circle of ureteroscopy. For all these three aspects are interrelated: the intrarenal pressure, the temperature, and the access-related problems. All of these aspects of flexible ureteroscopy are interrelated when it comes to complications in the procedure. And my statement is that the majority of complications in flexible ureteroscopy are related to the intrarenal pressure, because it affects both the septic complications, the access-related complications, and also the aspects around the temperature. So how can we decrease intrarenal pressure? Well, it has been shown in several studies that ureteral access sheaths unequivocally reduces intrarenal pressure during flexible ureteroscopy. This is one of the old studies which now have become classic from the Preminger group in the United States. And they unequivocally showed that when using a ureteral access sheath, the pressure were lower. They were able to do flexible ureteroscopy at a much lower pressure. They used 12-14 or 12-14 sheets. And when it comes to using ureteral access sheaths, there are a few truths that I will share with you. Of course, as shown in this study by Senner and co-workers, it's important to choose a ureteral access sheath that is compatible with your ureteroscope. However, there are a few statements which I consider truth in regarding ureteral access sheaths. And one of them is that to maintain a low interpelvic pressure and acceptable flow rates during flexible ureteroscopy with laser lithotripsy, the ratio of endoscope sheath diameter should be kept below 0.75, as has been shown in the study of Fang and co-workers. And by keeping this below 0.75, you will have a good balance between intrarenal pressure, irrigation, flow, and in order to reduce the temperature and have a good vision. And definitely the pressure flow irrigation relation favors a smaller ureteroscope in any ureteral access sheaths. And this comes both with regard to favorable clinical outcomes, as has been shown in the study on the left by Comeyer and co-workers, and also regarding intrarenal pressures and regarding lowering temperature during ureteroscopy using high power lasers, because when you have sufficient irrigation, you don't see these significant temperature rises. The other statement I consider truth with regard to ureteral access sheaths is obvious, because the ureteral access sheath necessarily has to be bigger than the ureteroscope. And this makes the urethral access sheath a potential double-edged sword. On one hand, it decreases intrarenal pressures and gives us a better balance between flow and pressure. However, on the other hand, it increases the strain on the urethral wall, and has been shown in several publications that when placing a urethral access sheath, this in some cases will result in lesions to the urethral wall, as shown as in this, I would say now rather classic paper by Traxler and Thomas, in which in considerable amount of patients urethral lesions were seen. In this study, 14 French urethral access sheaths was used, and they also showed that pre-stenting decreased the risk of severe injury 7-fold, and this is because by pre-stenting you are making the ureter into a dilated, adynamic system. We have shown in experimental studies that definitely when placing a urethral access sheath, you will affect the urethral wall. In this study, we showed that there was a dramatic increase in pro-inflammatory markers such as cyclooxygenase 2 and tumor necrosis factor alpha. And also we looked into the histopathological changes when we are placing a urethral access sheath, and we evaluated the histopathological pictures of the urethral wall lesions after US placement, and it revealed a significantly higher degree of severity than observed endoscopically. So clearly, endoscopy underestimated the histopathological extent of the lesions. Whether this has any clinical implications, we don't know. However, we studied this further in a clinical scenario in a consecutive group of patients in which we used a smaller sized urethral access sheath, 10-12 urethral access sheaths, and it was clearly demonstrated by downsizing the sheath. We have the extent of the urethral lesions was much less. So by downsizing the urethral access sheath, you can downsize the potential lesions. However, by downsizing the urethral access sheath, you need a smaller ureteroscope to have a good balance between pressure and irrigation flow. So definitely access safety favors a smaller ureteroscope, both when it comes to safety aspects and efficacy aspects. So again, looking at the pathophysiological circle of ureteroscopy, definitely small size matters in flexible ureteroscopy. It affects both the intrarenal pressure, the temperature, and the access aspects in a favorable manner. So by downsizing your instruments, our instruments, we can safely say to our patients that we will take care of your tube and make it into our tube. And by downsizing the instruments, we have got a valuable instruments for personalized to take into the future. Thank you very much.
Thank you, Palle, for this as always, beautiful and perfect talk, and this so well-known international PSA approach. Palle, just a quick question, maybe a little bit challenging, but do you think that by using smaller and smaller ureteroscope, that we still need actually to use ureteral access sheath to increase the backflow, since we have more space into the ureter, and especially if the patient is pre-stent? Do you think that we still need actually to use more or less systematically ureteral access sheath?
I clearly think that we will be using urethral access sheaths less in the future, because these small scopes will allow the drainage alongside the scope. So definitely, and especially if patients are pre-stented, we will have a system that will allow the volume of what we are irrigating to flow down alongside the scope. What we also should acknowledge is that actually when we are using a urethral access sheath, the fluid is coming out of the patient. If we are not using a urethral access sheath, it will accumulate in the bladder. So without using the urethral access sheath, we'll have to take care of the bladder filling, because that will contribute to the pressure in the upper tract.
Yeah, I think it's an excellent comment, Palle. So maybe we need maybe to discuss with the companies to develop something to drain the bladder and maybe not drain the kidney in the future. Very interesting. Thank you, Palle.